Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I'm about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession, who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 139 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads: which of the systems listed below would result in the quickest identification of Stenotrophomonas multifilia from a blood culture? Would it be A. Biomaru Vitek 2, or B. Biofire film array, or C. Luminex verigine? Or would it be D. MalDTOF? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is D. MalDTOF. Biofire film array and Luminex verigine are quicker to identify pathogens than the other two answers. However, neither detects Stenotrophomonas multifilia. MalDTOF is significantly quicker than commercial automated systems, such as Vitek 2, in identifying pathogens. And the next question reads: DMS, a 75-year-old female patient underwent a bowel resection in your OR. She has now developed a gram-negative bacteremia. Your clinical microbiologist detects CTXM producing Escherichia coli using Verigine gram-negative panel. So my question to you is: which of the regimens listed below would be the most appropriate therapeutic option for treatment of DMS's bacteremia? Would it be A. Ceftriaxone, or B. Ceftazidime avibactam, or C. Meropenem? Or would it be D. Piperacillin tazobactam? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Meropenem. Meropenem would be the best choice for this patient given production of CTXM, which is an extended-spectrum beta-lactamase. Piperacillin tazobactam is likely less effective than carbapenems. As has been shown in recent data, ceftriaxone is unlikely to be susceptible for CTXM-producing organisms. Ceftazidime avibactam likely would be active. However, it is unnecessarily broad coverage for an ESBL-producing infection. And the next question reads: FVL, a 47-year-old male patient, a known IVDU, presents to your infectious diseases clinic with MRSA, bacteremia with a vancomycin MIC equal to 1 mg per liter and is admitted to the general medical ward. He has an abscess on his right forearm. The infectious diseases consultant initiates FLV on vancomycin IV 1.5 grams twice daily. Vancomycin concentrations on day 3 of therapy reveal a trough drawn 30 minutes prior to the 6th dose of 15 mg per liter and a 24-hour AUC of 300. So my question to you is: which of the strategies listed below would be the most appropriate action for vancomycin dosing in FVL's clinical scenario at this time? Would it be A. change to 1 gram IV twice daily? Or B. change to 1.5 grams IV thrice daily? Or C. change to 1 gram IV thrice daily? Or would it be D. No change, patient is at goal? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Change to 1.5 grams IV thrice daily. Given that the patient's current AUC is below the vancomycin AUC to MIC ratio goal of 400. An increase in dose would be most appropriate, even though the patient has a trough that aligns with previously recommended goals. That is, trough values of 15 to 20 mg per liter. Changing the dose to 1 gram every 8 hours may affect measured trough but has no effect on the AUC. An increase in dose to 1.5 grams every 8 hours should yield a 24-hour AUC of approximately 450. Let's advance to the next slide, please. And the next question reads: SGER, a 65-year-old female patient who was admitted to your critical care unit following a cardiac arrest is now diagnosed with VAP by the infectious diseases consultant. SGER's blood and bronchoalveolar lavage cultures went Enterobacter cloacae complex. To which of the antimicrobial agents listed below does the highest risk of emergence of antimicrobial resistance exist while on therapy for invasive Enterobacter cloacae complex infections? Is it 2, A. Ceftriaxone, or B. Meropenem, or C. Ceftazidime avibactam, or is it 2, D. Cefepime? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Ceftriaxone. Enterobacter cloacae complex as well as Klebsiella aerogenes, formerly Enterobacter aerogenes, has the ability to repress production of AMP-C cephalosporinases in response to treatment with some agents. Cefepime and meropenem are poor inducers of production and poor substrates for AMP-C. Avibactam provides protection against hydrolysis by AMP-C, and ceftazidime avibactam generally retains activity against AMP-C hyperproducing isolates. Ceftriaxone is a strong inducer of production and a substrate for AMP-C. Development of resistance on therapy has been reported in the clinical setting, and treatment of invasive E. cloacae complex infections with ceftriaxone should be avoided. Kindly advance to the next slide, please. And the next question reads: which of the statements listed below describes the proposed mechanism of synergy between ertapenem and meropenem against KPC-producing Enterobacteria Shea? Is it A. Ertapenem induces the production of PBP2, the primary target for meropenem? Or B. Ertapenem and meropenem overwhelm expressed PBPs? Or C. Ertapenem opens the cell wall, allowing meropenem to bind to PBPs? Or is it D. Ertapenem acts as a suicide substrate? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Ertapenem acts as a suicide substrate. Ertapenem is thought to act as a suicide substrate for KPC enzymes, occupying the active site of those beta-lactameses, allowing meropenem to bind to PBPs, resulting in cell death. Ertapenem is not known to induce production of other PBPs and has a similar PBP binding profile to meropenem. Kindly proceed to the next question. And the next question reads: which of the pathogen identification systems listed below utilizes biochemical testing? Is it A. Microscan, or B. Film array, or C. Verigene? Or is it D. MALDI-TOFMS? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Microscan. MALDI-TOF uses ionized ribosomal proteins. Verigene utilizes nucleic acid amplification. And film array is PCR-based, therefore, microscan is the correct answer. Please advance to the next question. And the next question reads: which of the statements listed below most accurately describes the mechanism of MALDI-TOF-MS pathogen identification? Is it A. amplifies single strands of DNA for pathogen identification? Or B. amplifies ribosomal RNA for pathogen identification? Or C. creates a pathogen profile based on ribosomal protein composition? Or is it D. creates a pathogen profile based on enzymatic reactions? I will give you a few seconds to choose the correct answer to this question from the listed options. And the correct answer is C. creates a pathogen profile based on ribosomal protein composition. MALDI-TOF-MS creates a pathogen profile based on ribosomal protein composition. Enzymatic reactions and RNA and DNA amplification are not used in this technology. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of my senior colleague, Dr. Nath Arora, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video.